Okay, chapter 15 covers the head and neck. Uh, you should know where the bones of the head and neck are, mainly because, well, for one reason, because when you localize or when you describe findings, a lot of times we describe them in terms of those bones. Like we'll speak of a headache in the frontal area or in the parietal area, or that you found a certain lymph node in the occipital area, or things like that. So in order to do that accurately, you need to know where those bones are. So check the diagrams in the book so that you can see where those where the bones of the head are, as well as the bones of the face. The bones of the face we don't use so much in our descriptions, but the bones of the head you'll definitely see a lot of references in charting, like you'll see references in charting to where certain things are. In the bones in the face is important. It's important to know those for general knowledge. Most of the bones in the face are actually paired bones. There's one on each side. Important structures in the neck: the sternomastoid muscle, which goes downward at a diagonal angle from roughly from around your jaw area, a little behind your jaw down, and it comes down going forward on a diagonal, and it's the muscle that can bend your neck forward. And then the trapezius extends your head and neck, and it's behind the sternomastoid muscle. And these two are going to form two triangles, the anterior triangle and the posterior triangle, which are important landmarks. The 11th cranial nerve is the nerve that gives us the spinal accessory nerve, is the nerve that gives us the ability to shrug our shoulders. So that's important also to the functioning of the head and neck. And another important anatomical landmark is C7, or that's if you bend forward, in most people you'll see a lump in their neck, in the back of their neck, which is C7, and that's an important landmark both for finding where the other vertebrae are, as well as for example, when we're listening to lung sounds, we want to be sure to get the apex, the top portion of the lung, so we go to both sides of the of C7 as our landmark there for assessing lung sounds. So we use this C7 landmark for various reasons. Other important structures that you'll find in the neck: the internal jugular and carotid arteries, they go together, and they're in front, directly in front of the sternomastoid muscle. And then the external jugular is on top of the sternomastoid muscle. And these are going to be important later on when you're assessing heart and central vessels. And then the thyroid gland, which we'll be talking about later in this chapter, is also found in the neck. There are a number of lymph nodes in the neck area and head and neck areas, and you should know where they are and the areas that they drain, so that if you find a lymph node that's enlarged, then you're going to look for signs of infection in that or in that area that is drained by that lymph node. Pre-auricular are before, in front of the ears. Post-auricular are in back of the ears. And then tonsillar, occipital, submandibular, submental are beneath the chin. Superficial and posterior cervical and deep cervical. Look in the book where all of these lymph nodes are. And then finally supraclavicular. So you need to know where to find these lymph nodes so that you know where to palpate for them, because later on we'll be palpating for each of these lymph nodes. And also the area where that these are draining. So, history of present concern. Some of the complaints that people will have relating to head and neck, headache is a very common one, and you would do any of these complaints, you're going to do cold spa on the complaint. They may come with other types of symptoms relating to their head, symptoms such as dizziness, lightheadedness. They may come with facial pain or some other pain, neck pain, difficulty moving head or neck. And maybe they noticed a lump, a lesion, something new like that. So whatever the present concern is, you would want to do cold spa on that, and you may find related other concerns relating to head and neck as well, and you do cold spa on each symptom that the patient complains of. Dizziness, lightheadedness, and spinning sensation. These could be due to a neurological problem, but they could also be due to a ear problem, Meniere's disease or something like that. And then there could be other complaints that are not of the head and neck itself, but it could be related. It's like, for example, a change in texture of skin, hair, nails, or change in energy level, change in sleep habits, or any emotional stability. These all could relate to a thyroid problem, as well as if they felt palpitations, if they had tachycardia or bradycardia, even things like edema, constipation, diarrhea. Those could all be related to thyroid problems. Asking about the past health history, you would want to know about any previous head or neck problems that the patient had had, and specifically about any trauma. And sometimes, for example, a person may not really consider something trauma, like they just bumped their head and they felt sore, but they may have actually had a concussion or something like that. Any facial, head, neck surgery, and any radiation therapy in the neck region. Radiation therapy particularly could, after radiation therapy in the neck, there's a higher incidence of thyroid cancer, and there may also be swallowing problems that result from at a later time, that result from previous radiation therapy to the neck. If part of your differential headaches, as I was saying, headaches are a very common problem that people have, and one thing that can cause headaches is medications, and there is a large number of medications that can cause headaches, and probably not even half of those medications are listed here. There's a lot of different medications that can cause headaches. So that is one place to look for. And then there are even foods that can cause headaches in some people. Foods, drinks, all kinds of things. Some of the things that can sometimes cause headaches would be anything hormonal, like oral contraceptives or hormones that are used for menopause treatment, but also anticoagulants. And then both caffeine can cause headaches, but also withdrawal from caffeine. If you're accustomed to drinking caffeine and you don't get your caffeine, in my case, if I don't get my caffeine when I and sometimes, like, I don't even notice it, like maybe I for one reason or another I didn't drink coffee or didn't get my caffeine, and then I start getting a headache, and then as soon as I drink some coffee or caffeine, it goes away. A lot of people are like that. Nitroglycerin, and if you've given nitroglycerin in foundations, for example, if there's nitroglycerin ointment, and if you're not careful about wearing gloves when you wipe that stuff, or when you put the nitroglycerin patches on people, you can get that on your fingers and it will go right through your skin, and you can easily get a headache. That's happened to me on a number of occasions too. I finally learned to use gloves when I mess with nitroglycerin ointment. It's also something to warn your patient about, or sometimes you don't necessarily want to really play it up because the suggestion can give them a headache they wouldn't get otherwise. But if you don't, like, say you give that patient the first dose of nitroglycerin and then a couple hours later they're calling you and say, oh, I've got this horrible headache. Well, you probably would want to give them something else for the headache, because they probably do need that nitroglycerin. But then you should be aware that, oh, okay, well, the headache in this case is a side effect of the nitroglycerin. And this is true for nitroglycerin in any form. We give nitroglycerin sublingual. We give long-acting oral nitroglycerin tablets. And we give IV nitroglycerin, and then we give nitroglycerin patches and that nitroglycerin ointment that's dissolves through the skin. So we give the nitroglycerin through many different routes, and whatever route we give, it can cause headaches. Some of your antihypertensive drugs will also cause headaches, as well as some of the drugs we give for erectile dysfunction. And antihistamines and decongestants can cause headaches. Steroids, prednisone, solumedrol, all those drugs. And ergotamine, and paradoxically these ones are used for to treat headaches sometimes, but they can also cause headaches. Immunosuppressant drugs, some chemotherapy drugs can cause headaches. And even excessive amounts of vitamins A or fat-soluble vitamins. Radiation therapy itself can cause headaches. And then the main drugs we use to treat them, acetaminophen and non-steroidal anti-inflammatories, those can sometimes cause headaches too, as well as your opioids. As far as family history, we'd want to ask about any head or neck cancers, and we'd want to ask about if anybody in the family had migraine headaches. Then lifestyle and health practices. particularly we're interested in smokeless tobacco. Like, your patient, maybe you ask them, do they smoke? Oh no, I gave that up for my health. I just do my snuff now. Well, that patient is going to be that is actually a higher risk than smoking cigarettes of throat and mouth cancers. The smokeless tobacco is a very high risk for mouth and throat cancers. And cigars, even though you don't inhale, you say, well, I just smoke cigars, but that would be a higher risk for throat cancer as well. Alcohol is another risk factor, and street drugs. Then we would want to ask about safety, their safety practices, like using seat belts, using a helmet if they do motorcycle riding or contact sports, bicycle riding, things of that nature. What recreational activities do they do? Do they well, that will give us a clue as to their risk factors. And what's their typical posture like, particularly as far as the they have their spinal health and the neck health. So one of the things that we're concerned about in this assessment is both hypothyroidism and hyperthyroidism. And a lot of the symptoms of hypothyroidism are going to be opposite to the ones of hyperthyroidism, but not always. The person that's hypothyroid will probably be overweight, they'll have weight gain. They'll be sleepy, cold intolerance, muscle aches, fatigue. But then we get to menstrual irregularity. That can also be a symptom of hyper, that either hypo or hyper. They'll have menstrual issues. Pale, dry skin. The skin that would be typical of hypothyroidism, and then thin, brittle hair or nails as well. Then bradycardia, constipation, edema, and then just general mental slowness. They'll be forgetful, they'll have trouble concentrating, but the hyperthyroid person will also have trouble concentrating, but their mind is racing, where this person's mind is just slow. And they may have a higher diastolic pressure too. Hypothyroidism sometimes can result when the person was hyperthyroid at one time, and so in order to treat that, we had to the physician had to destroy part of, or all of the thyroid, and then we just give them thyroid pills. Well, as long as they're taking their thyroid pills and the levels are appropriate, they'll do fine. But if for one reason or another they stop taking the thyroid pills, then they'll develop hypothyroidism. That's a pretty common reason that you'll see hypothyroidism, is the person was on thyroid medication and they just stopped taking it. Hyperthyroidism, that's the person that's going to be thin. They'll eat a lot, but they don't gain weight. They're nervous. They've got poor concentration. They're tired, but it's from nervous tired. They're not tired like the hypothyroid, that tired and slow. They're tired because, oh, I'm just so exhausted. I'm just running and doing, I can't keep up. They may have palpitations and tachycardia. They'll be heat intolerant, sweating. They'll have possibly have dyspnea and maybe diarrhea. And they probably will have insomnia, and maybe oligomenorrhea is like they'll skip periods from time to time. some weight loss, hair loss. The proximal myopathy, that means the muscles that are or the proximal muscles will be affected, not the distal muscles. Warm, moist skin, hyperkinesis, their movement, all their reflexes and movements are just exaggerated. And they may have the characteristic staring, and they may even have their lid retracted to where they aren't closing their eyes properly, and so they may have corneal damage as a result of not actually closing their eyes, so the cornea dries and becomes damaged. And their eyeballs are bulging, appear to be bulging. They'll be maybe very emotional and kind of go to emotional extremes, and you may actually palpate an enlarged thyroid, be able to palpate it too. Then another topic in this chapter is traumatic brain injury, and there's a section about that in the book. Be sure to read that. Traumatic brain injury is one of the goals for Healthy People 2020. Our government has set the goal of reducing traumatic brain injury and improving care of people with traumatic brain injury. There's a concussion is a lighter form of traumatic brain injury, and a lot of people have concussions and aren't even aware of it necessarily. Like a concussion is a brief period of either loss of consciousness, change of consciousness, or some memory loss following head trauma. And a lot of people will maybe have those maybe in a sports injury or something, and they don't really think about it at the time, like they're stunned, but they just get up and they're not really aware that that's happened. And one of the dangers of that is that if you have, like for example, boxers, football players, where you have various concussions, why then the damage can add up over the years, and you have early onset of dementia. That's a serious problem with some of the older athletes. Then their severe brain injuries are where you have extended memory loss or unconsciousness following the injury. So that would be somebody perhaps in a similar injury to the concussion, but they're unconscious for a while, and then they have an extended period of memory loss after it. Probably many of you have experienced concussions. I hope none of you experienced severe brain injuries. Well, really, I hope none of you experienced concussions either, but it's kind of I did experience a concussion, and there's a little gap in my memory where the situation was that I was in a scuffle and got my head hit, and I walked in to there's maybe 10 minutes or so that's lost from my memory, where I walked into the nurse's station and was talking to my charge nurse, and she said, "You don't look good." I'm saying, "Oh, I'm fine." And then next thing I know, I was in the emergency room on a stretcher, and they told me, well, I have no memory of how I got from the nurse's station to the emergency room. So that period of 10 minutes, I've never remembered that at all. And, people just told me about it and filled me in on the details and all that, but I just have no memory of it whatsoever. people that are at high risk, there's three specific age groups: young children, young adults, and older adults. They're at higher risk, but of course anybody can have brain injuries. But young children, because they take risks, they lack judgment. Young adults in the 18 to 22 age group, somewhere around there, those ones also, they take risks and do all kinds of things. And then older adults, particularly from falls. And the risks are going to be different depending on which age group you're in, but those three age groups are all at higher risk. So some of the things, motor vehicle accidents are a big source of traumatic brain injuries, whether it be car accidents, motorcycle, even bicycle accidents, falls, especially in the elderly, and then blows to the head, which could be either from a criminal assault or from some other cause. And then sports injuries, especially like football, boxing, those kind of things. Combat, anything to do with the military and combat. And then explosion. And not surprisingly, males are at higher risk of traumatic brain injury than females. So some of the things you would want to ask about in your assessment would be if they had a history of traumatic brain injury, but then you might also want to ask about a history of if they'd ever lost consciousness, because they might, if you said traumatic brain injury, oh yeah, I played football, I got hit in the head all kinds of times, but they wouldn't necessarily consider that traumatic brain injury. And then you say, well, did you ever have a memory loss or consciousness? Oh man, yeah, we were playing that other team, and yeah, I was. So they'll tell you maybe. So if you ask it in that way, why then maybe you'll uncover some information. And then other things would be if they ever were hit in the head and they had a behavior change afterwards. Particularly if it was a prolonged behavior change. Or if they ever had difficulty concentrating, organizing their thoughts, or remembering things following a blow to the head. So the risk factors, to summarize: age and gender, what kind of transportation. Obviously, somebody that rides a motorcycle without a helmet is going to be at higher risk than somebody that only rides the bus or train and doesn't even get in private cars hardly. Violence and caregiver abuse. So that could be like caregiver abuse could either be like children who are left with caregivers that are abusive and hit them in the head or shake them and cause brain injuries by just shaking in babies, or older adults too that are subjected to caregiver abuse. Also people at risk for falling, and that could be greater or lower depending on things like your lower body, your lower muscle, your lower body strength in the case of older adults, and if your house has been assessed by maybe a public health nurse or somebody like that, and equipment to prevent falling has been installed or not. And then of course use of alcohol and other drugs will increase the risk of brain injuries. So the education we're going to give to patients is age specific. You're going to be teaching some things to the parent of a young child and very different things to older adults. and look in the section in the chapter for some specifics. Some generalities, you'll want to teach about use of seat belts and also child car seats and helmets, both for sports and for motorcycle, bicycling, and even construction and other areas where you might be subjected to head trauma. Of course, you'd want to educate about the risk of driving while intoxicated, and you'd want to discuss removing hazards from the house, especially in the case of older adults who may you'd want to remove anything that might cause them to trip, and install things like handrails and things like that to help prevent falls. Another approach in fall prevention with older adults is to try and improve lower body strength, and a lot of times exercise is used for that. It's kind of a delicate thing. A lot of times when we get an older adult in the hospital, we want to say, oh, don't get up, don't do anything, we'll just take care of you. But we may be doing more harm than good with that, because if you allow the person to you keep them from getting up and allow them to deteriorate further, and their lower body strength gets worse, why then you may be increasing their risk of falls instead of decreasing it. Another approach to take is trying to modify the surfaces where a person may fall, and so that would look different on different age groups, but maybe putting in, instead of like concrete, putting in padding or carpeting or things to kind of soften the surface where a person will fall. In the case of children, making sure that the playground, instead of concrete, make sure that playgrounds have like sand or surfaces like that, where if they do fall they won't be as severely injured. And then maybe modifying sports practices, like there's some discussion of even changing football rules and things like that to prevent head injuries. And then there are even some parents that are saying, well, I don't want my child playing football at all. I want them to play other sports where they're at less risk of getting head trauma. So, turning to objective assessment, you start by assessing the head for its size, shape, configuration. You may see microencephaly or acromegaly are the two things that the book mentions that are differences in size and shape. Palpate the head and be sure to use gloves when you do, because you may get secretions that are not obviously apparent. Then inspect the face, and you're looking for symmetry, and you especially would want to look at the nasolabial folds and the eyebrows, the palpebral fissures, to inspect for symmetry. And some of the things you'll be looking for, you want to see if there's an asymmetry. There might be drooping either on one side or the other, and that could be due to a stroke, but it could also be due to Bell's palsy. And another abnormality you might see is a mask-like face that's really characteristic of Parkinson's disease. Then you'd palpate the temporal artery. The book mentions that if the temporal artery is impaired, that can lead to be a sign that blindness is impending if the temporal artery is impaired. So that's the importance of the temporal artery. Then you'd also palpate the temporomandibular joint and inspect the neck position. You want to look for symmetry, for masses, for any lumps when you do that. Asymmetry of the neck, especially you might see asymmetry of the trachea, and that could be due to a lung problem such as atelectasis or pneumothorax, or it could be due to a tumor. It could be due to various problems like that. In the case of things like atelectasis and the lung problems, why the side that the trachea is going to be pulled toward the side that the problem is on, the pneumothorax or the atelectasis. But in the case of a tumor, it's going to be pushed away to the other side. Observe the neck structures. Ask the patient to swallow and observe the neck structures, and you're looking to see if you can see any thyroid abnormality there. And you'd want to inspect the cervical vertebrae. As we said, when you bend the head forward, normally you'll see a lump that is C7, but maybe in some cases you may see other vertebrae bulging as well. That would be an abnormal finding. Inspect for range of motion of neck, but if the person complains of pain, why stop? If they have pain when they're moving their neck, you'd want to evaluate further to make sure they don't have a cervical spinal injury. So you wouldn't want to try to force them or try to do passive range of motion or things like that. Then palpate the trachea and then palpate the thyroid. You palpate the trachea from the front, then you get behind the person to palpate the thyroid. Most of the time you won't feel a thyroid. Sometimes you will. If the thyroid is enlarged, then you'd auscultate and see if you hear a bruit there. And then you palpate the lymph nodes. Remember all those lymph nodes we mentioned on a slide earlier? You would palpate, and that seems like a lot, but actually when you get into doing them, you can palpate them fairly quickly. Generalities of palpating lymph nodes. You use your finger pads and you do slow circular motion. And have the person bend her or his head slightly toward the side that you're palpating on to help relax. And you want to assess if you do palpate. Normally you will not palpate lymph nodes. Occasionally you will palpate them, and you would want to, that can be normal. If they're not enlarged, they're not tender, etc. We'll see what's normal and abnormal in a minute, but normally you will not feel most lymph nodes, and occasionally you'll feel them, and then you'll want to assess for their size, their shape. Are they delimited or confluent? Meaning, each lymph node is independent, or are they flowing together? Mobility, do they move or not? What is their consistency? Are they hard or are they soft? And are they tender or not? So those are the things you want to assess if you feel one. The normals, look in the box in the chapter where it talks about this, but some of the normal things, lymph nodes are discrete. Discrete lymph nodes are normal, although they can be discrete in acute infection as well. After chronic infection, they'll probably be confluent. Normally, they're also round if you do feel them. Well, they're round, and then they should be less than 1 centimeter. They should be mobile soft, and non-tender. Abnormals greater than 1 centimeter, if they're confluent, they could be fixed, hard, firm, tender. Those are all abnormal findings. And then there are 3 different definitions that are given. Lymphadenopathy, which is simply where you find enlarged lymph nodes in one area. Regional lymphadenopathy is where you will find them in more than one area, and then generalized lymphadenopathy is further lymphadenopathy, and that's typical of severe autoimmune diseases such as AIDS. So, all with our findings now, we'll give we will give the person some diagnosis, and we might give a health promotion diagnosis, such as, say, if the person says, well, you know, I'm going to try and give up this smokeless tobacco because I'm worried about the possibility of getting mouth cancer. So then we'd give them a diagnosis of readiness for enhanced health management. A risk diagnosis could be risk for injury to head and neck related to use of football, or related to use of motorcycle without a helmet, those kind of things. Then as far as actual health diagnosis, ineffective health management related to tobacco use as evidenced by continuing to smoke. Imbalanced nutrition, more than body requirements, related to hypothyroidism as evidenced by weight gain of 5 pounds over the last month. And then we could have imbalanced nutrition less than body requirements in the case of say either hyperthyroidism, or maybe somebody that had a swallowing problem could have that problem too. And we could have chronic pain related to something as evidenced by something else. Disturbed body image, that could be related to, say, a head injury, or it could be related to the weight gain from the hypothyroidism, or it could be, there's a number of things that could give us a disturbed body image. Impaired swallowing, again, that could be due to a number of different things too. Referrals are collaborative problems, so we may come across things that, you know, well, we can't as nurses take care of this, but this is rather alarming, like risk of complications, hypocalcemia, that calcium is too low. And you're saying, what on earth does calcium have to do with the neck? Well, think about it. What regulates calcium? The parathyroid glands, and the parathyroid glands are in the neck, so we could have hypocalcemia or hypercalcemia. We could have corneal abrasion. Oh, well, how would we get corneal abrasion? Again, hyperthyroidism. If you aren't closing your eyes effectively, you can get a corneal abrasion as a result. Risk of complications for thyroid crisis. Sometimes the hyperthyroidism gets so bad that the heart is affected, so it can become a life-threatening problem. Risk of complications for CVA. If you suspect somebody is having a CVA, that is a medical emergency. You would not try to treat that as a nurse. You would have to alert the emergency response system, wherever that may be. If you're out in the community, you would call 911, but if you're in a hospital, why they have codes for strokes, they have codes for various rapid response problems that you might have. Risk of complications for seizures. Again, if you think somebody is having a seizure, you would not sit around, well, I wonder what nursing interventions can I do for that. You would want to immediately get medical help for that problem. Risk of complications for cranial nerve impairment. Well, that could be something that you wouldn't necessarily do immediately, but depending on the problem, if you thought somebody was at risk for choking, for example, because of a vagus nerve, why then you would probably want to make the person NPO and then alert the physician. Risk of complications for increased intracranial pressure. When we get to the chapter on neuro, we'll see more about increased intracranial pressure, but that is another thing that's a medical emergency. And when we started, we were talked about, at the beginning of the chapter, we talked about headaches. So there are various types of headaches, and some of them are here. In the book, there's a table that helps you to differentiate between headaches. I've had students in the past that will fixate on certain things in the table, and when they get to a test question like which feature would best differentiate this headache as a migraine headache, and then they say, oh, well, my answer is good because migraine headaches are brought on by drinking alcohol sometimes. And I say, well, yes, they can be, but cluster headaches can be as well. So what we're looking for here is something that is unique to migraine headaches. So look in that table for things that are unique to each type of headache. And then you want to read, of course, the general characteristics of those types of headaches too. But and then, it's important on all of your test questions to read the stem carefully, because sometimes students, it'll say, sometimes we get questions like, the nurse suspects that this patient might have such and such. What would help provide more evidence for this supposition? And so then we might have some answers that do go with that problem, but they're not really going to provide more evidence. So if you're looking for example, if you're looking for something again with the migraines, what would give greater evidence? Probably this the prodromal stage might be something, or that if it's accompanied by light sensitivity, that might be an indication. But if it's something like it's just on one side of the head, well, that might too. But yeah, you wouldn't want, or if it's just severe, the headache is severe, well, that's true of migraines. They're usually severe, but so are the rest of them. So be sure to read your test questions carefully and see if the answer you're choosing, sometimes the answer you're choosing is something that is characteristic of what we're asking about, but it's not necessarily something that actually answers the question. So read your test questions carefully and That's all I'm going to say about that.